Hi, everyone. Thanks for joining us in this American Journal of Psychiatry Residence Journal podcast. My name is Dr. Aaron Wolfgang. I'm one of fourth-year psychiatry residents at Army Medical Center. Also joining us as one of the interviewers today is Dr. Sean Wilkes. He's a child psychiatry fellow, also at Army Medical Center in Hawaii. And lastly, also joining us is Dr. Alexander Kaplan, who is joining us from the Javits Center at New York City. And he's a newly minted attending psychiatrist who just last year was the chief resident at Army Medical Center, and is joining us from New York City and will be talking to us about his experiences there. I would also like to add that although Dr. Wilkes and I are in training and Dr. Kaplan is an attending, we are also all active duty Army officers. And because of that, we also want to preface this podcast by saying that the views expressed in this podcast are entirely our own and do not reflect the official policy or position of the Department of the Army, Department of Defense, or the U.S. government in any way.
Yeah, welcome, Dr. Kaplan.
Thank you. It's good to be here. I'm actually not at the Javits anymore. Javits has discharged its last patients and has shut down, but I am in a beautiful New York City hotel room where I've been for the past week in isolation.
Dr. Kaplan, would you mind telling us a little bit more about yourself, just in general?
Yeah, so as Dr. Wolfgang mentioned, I did my psychiatry residency at Army Medical Center. And I am currently stationed at Fort Hood, Texas, where I'm the medical director of the inpatient psychiatry ward at Carl R. Darnell Medical Center. But I am assigned to the 1st Medical Brigade, which is a medical combat unit or brigade at Fort Hood. So when missions like this occur, though we may work at the hospital or in clinics, we belong to the brigade or whatever unit we're in, and thus are basically pulled for the mission or deployment. So in this case, I work at the hospital, but belong to my unit. And that's kind of how this mission kind of started for me, is the 1st Medical Brigade was asked to be an integral part of this mission.
So you've been at the Javits Center for about the past month until it closed down last week. Tell us how this all began. How did you wind up there at the Javits Center?
So you get the phone call saying prepare to deploy. So PTDO, prepare to deploy orders, and basically very quickly we were asked to kind of tie everything up at work in a bow. Luckily, on an inpatient psych ward, I have other psychiatrists that I work with and great guys, so they were very amenable to covering for me. And then you grab your gear, pack up, and get ready to go. So a lot of it is paperwork and preparation before, but it was pretty quick process. So we flew into a different base where we were kind of, mobilized through and moved pretty quickly to the Javits Center. So it was really a few day process from when I got the notification that I would be moving to when I actually stepped foot through Javits. And so 9th Field Hospital, which is part of 1st Medical Brigade, as well as the 531st Field Hospitals, were the 2 Army field hospitals that were really put in charge and led the way of the Army aspect of the mission at Javits. But I think it's important to note that there were Army active duty, reserve, as well as Navy, U.S. Public Health Service, Air Force. I mean, really every Health and Human Services, really every branch you can imagine.
All right. And could you mind taking us through that experience, or what your experience was of when you learned that you're going to be deployed? Just taking us through your thoughts and feelings, just the range of emotions and just your experience of finding that out.
Well, I think when something infectious like this comes through, it's always hard to tell if you're catastrophizing, right, or if everybody else is minimizing. And that's definitely kind of that conversation I was having with myself in the weeks leading up to the mobilization. However, towards the final couple of weeks, I was getting a little more concerned about the effect that COVID was having on our country. So I was not surprised to get that phone call. Obviously, there's a mixture of emotions, right? There's some anticipatory anxiety which I think is very natural, and some excitement as well, right? Like for us, those of us that signed up, right? Humanitarian missions are part of the reason why for many of us. And to do so on American soil has its own special meaning. I mean, the United States Army has never mobilized on American soil in a medical capacity like this. So it was very much a unique experience and exciting to be able to be part of. Obviously, as the process went on, everything from excitement to anxiety to, some tough days, some, very touching moments, it was really the gamut of emotions and experiences, which also are why things like this are so important developmentally for us, or for me at least.
Yeah, and thanks for taking us through that. And so once you land on the ground, what happened once you actually landed there? And do you mind taking us through at least your first few days at the Javits Center and what your experience is like there?
Yeah, so for operational security, I can't go into details, but basically you land at one base and you're processed through, right? You might stay at the barracks there, and then you're moved to where you'll be settled down, which for me was a hotel near the Javits Center. And then once at the Javits Center, there really was a pretty quick series of events because the hospital was being built as we were almost using it, right? Like building the plane as you're flying. There's not a formal SOP in place. There's not formal orientation in place. You show up, you figure out the dynamic and changing command structure, leadership structure, kind of fit your way into it. In the beginning, the primary concern was, oh man, do we have enough providers? And most of us were specialists. The first group of providers were, I could probably count the primary care docs on one hand. And so most of us were surgeons, OBGYN, psychiatry, things like that. So though I showed up raring to do psychiatry, I was told, what we need right now are hospitalists. And so we all formed basically multidisciplinary teams so that we could minimize each other's weaknesses and maximize each other's strengths in order to run hospitalist teams when patients were admitted. And so pretty quickly, once we got on the ground, the first patients came in, and we were able to use those opportunities to adapt and find weaknesses in our system and find solutions pretty quickly, because with each patient, right, they're presented unexpected challenges and problems that had to be solved very, very quickly. And the team of doctors, nurses, pharmacists, everybody that we had were very flexible, very proactive in solving those problems, which is one reason I think we had so many positive outcomes and such a low mortality rate at our facility.
So what was seeing patients like as a psychiatrist working as a hospitalist, basically?
Initially terrifying, right? So when I first found out, oh, you're going to be a hospitalist, I think a natural reaction is, oh, no. Like, not only are you, working with acute internal medicine, you're adding this mysterious virus, which every day seems to present with new and odd symptoms and, something we didn't quite understand. Now, initially we were a non-COVID mission, right? But we knew, the way we were treating PPE and the way we understand infectious disease travels, we knew there would be COVID at some point, right, in the building. And so obviously it was nerve-wracking, honestly, when I first found out. But I'll tell you, the anticipatory anxiety was way worse than any stress of actually doing so. It's amazing how fast you pick up what you learned in residency, and thank God doing inpatient psychiatry, forces me to stay on top of a lot of the internal medicine, at least chronic illnesses. In addition to that, we got a lot of patients that had neurologic disorders, had a lot of major neurocognitive disorder and comorbid psychiatric disorders. So our skill set actually, even from day one, the first patients we admitted were valued and used, even if we were formerly hospitalists. We were taking psych consults, we were taking the dementia patients, and we were really trying to proactively provide the psychiatric care on top of the hospitalist care.
So what would you say was your primary or most impactful role while you were there? What did you spend most of your time doing?
So I would say I saw patients for approximately a month. I think I've been here about 6 weeks, just over 6 weeks. The first half of that period of time, 2+ weeks, were spent in the hospitalist role. Again, in the multidisciplinary teams, which towards the end of the second week really got fleshed out with a lot more primary care, critical care docs. We really had the system, it was much smoother at that point. The second half, I was given the green light due to really the need to set up and run a psychiatric CL service. And we did not set it up like a standard CL service, standard hospital, primary care, primary team consults. What's the consult question? Go see the patient, close the loop, right? We had to set up where anybody could come to us and say, even, patient in pod 13 is crying, right? That was enough for a consult. So the goal wasn't just the consultation part of the CL, which I think sometimes we put a lot of stress on and forget the liaison part. It was really also to decrease the burden on staff, that emotional burden, or the temporal, the time-related burden of working with patients that sometimes were difficult, had dementia, had their own family members dying from COVID, were terrified of having the infection, or had anxiety related to dyspnea, a whole kind of gamut of symptoms. We were also able to kind of leverage that and keep an eye on the staff and the providers too. Our nurses in particular were working very long hours, working days and days at a time. And just like us, we're often working outside of their usual specialty, right? So we had, post-op nurses that were, working kind of critical care roles, things like that, and really owning it, doing a wonderful job. But it's stressful. And there were certain periods of time where we were admitting patients at a very, very quick clip. And so being able to be there and just kind of check in, identify staff that were struggling early on, provide interventions on the spot, or set up outpatient kind of care, which we did early on. We were able, I think, to minimize the potential harm that could have occurred just from the stress of the mission.
Awesome. And so it sounds like you're describing a lot of kind of features of disaster psychiatry, almost in terms of, putting yourself out there and being a resource. Do you mind going a little more into what exactly was your role and what exactly, did you do in terms of putting yourself out there and, letting your name be known and providing that care not only to patients, but also to staff?
I think it was important early on to identify what was important to the Army / the mission, right? Which in this case was be a hospitalist, provide care to COVID and then non-COVID patients. And then what's important to me, right? Like I knew that the staff and all of the military folks coming in were going to need psychologic support, and the patients obviously were going to need psychiatric support, right? So to be able to fulfill all those roles, right? What's important to them and what's necessary for the mission, what's important and necessary from my perspective. We took advantage of the earlier days where there were not patients coming through at a high clip to set up those outpatient services, to set up SOPs, and to locate ourselves in high traffic areas, right? And to present ourselves not as behavioral health or mental health clinic, but a resilience center where people could come in and chat or just grab some water, basic needs, and have kind of like a safe space where if people then wanted to, seek out more care, or if someone was identified later on and needed care, then we'd be able to bring them through that, staff support center, basically. And from the inpatient perspective, we did the same thing. We love providing psychiatric care. So though we were functioning as hospitalists, the team was more than happy to allow us to prioritize and care for patients with psychiatric and neurologic comorbidities, and doing rounds, not only on the patients, but on the nurses and the medics and the entire medical support staff, right? Just saying, hey, what's up? How you doing? Not, hey, this is Dr. Kaplan, the psychiatrist, checking on your mental health, right? Making it casual, developing those relationships, gave people the opportunity then to feel safe in coming to us and coming to me when the time was right, if they needed it. In addition, being present. is just incredibly important. So in reality, you have to sometimes talk to the right people to get things done. And so I would make a point to help out those in higher leadership positions that might have, again, difficult patients, or that might need help with something that might not be related to anything psychiatry or medical related at all. And physically, the command structure was located in one aspect of the building. So I made a point every day to walk through and check in and say hi, see how people were doing. Again, just developing those relationships, facial recognition, and to be able to see what I can do to support them. And in return, they did a great job and supported us. When they had the ability, they gave us the okay for the psychiatric CL service. When we asked for extra support for certain aspects of our medical support staff, because we had those relationships, we were able to be respected, be heard, and be able to take time from busy people to be able to intervene and help people that might be struggling.
Awesome. And so both Sean and I have the great fortune of knowing you personally already. From what we know from being a year behind you in residency is, for one, you're an excellent clinician. And I know that firsthand from working with you side by side on different services and on call. But what we also know about you is that you're also an excellent leader and everything that comes with that. Again, we know that from you having been our chief resident last year and having really not only taken care of the patients in front of you and on your service, but also taking care of the residents within your program. And so for the benefit of everyone else listening, do you mind taking us through in what ways did your military residency training prepare you for this experience?
So I would start with the most obvious, which is I was operating in a medical military environment, right? With a whole another, language and a whole other structure. And so obviously having a psychiatric military residency training set me up for that. But in addition, our program, and Walter Reed is a phenomenal program as well. I think both psychiatric programs really put a lot of emphasis on leadership and, forms of leadership, forms of communication, how to manage up, how to manage down and laterally, right? Things that are often hidden curriculums really became part of our non-hidden, really, concrete curriculum. And so by doing so, and by our leaders, including our program directors and attendings, modeling that behavior, but also verbally communicating that it was important, allowed us to value it and to also have a safe space to trial it, right? Because you have to have the opportunity to lead and fail, and to provide medical treatment and fail, and to do a lot of things and fail. And residency is the place to do that, to take those chances, because in a good residency, you're set up with a safe space where you have the ability to have clinicians and leaders that can back you up and make sure that even if you fail, no one is harmed. Maybe your ego a little bit, but that's okay. We could all use that sometimes.
Did you feel ready for that role, that being kind of thrust into that leadership contingency medicine role?
I think, my personality type. For me, it just kind of happens. I was the lowest ranking psychiatrist there, but I ended up leading psychiatric services at Javits. We also transitioned to telepsychiatry or telebehavioral health really towards the end when everything was transitioning towards civilian leadership, and I took the Army lead on that. And so I think I kind of, because I'm vocal, because I show up and I'm present, it just kind of happens. I would say the more stressful aspect would have been the clinical moments early on, and then just the things that would be expected, the long work hours, trying to provide be a rock in a very turbulent area, right? And to provide care for others while maintaining your own emotional health, right? And not burning out.
So thinking a little bit more broadly beyond just the mission at the Javits Center, what unique skill sets and capabilities do you think military psychiatrists bring to the table in this crisis more generally?
It's difficult to answer that question because you don't know what you don't know. So the world I know is one which I've gone through a military, psychiatric residency, and I have not gone through a civilian psychiatric residency. So what I say next comes with a grain of salt, and I apologize if I am incorrect. I do know in our environment, we were taught other things in addition to psychiatry and medicine, right? So leadership was very important and prioritized, as were aspects of a military environment, officership, and problem solving in other manners, right? So we would have days, while in residency where we would go do things that had nothing to do with psychiatry, right? Like, going out and doing combat medicine, right? C4, things like that, or leadership courses. And so I think that expectation that you are a psychiatrist, you're a doctor, but you are also an Army officer, and you are also expected to lead and to care, for the others around you, and to problem solve in ways that are not within your quote unquote wheelhouse. Just having that kind of mindset sets you up for just diving into whatever's happening.
Speaking of which, in terms of your military residency, kind of emphasizing leadership, and you kind of emphasizing how those skills have allowed you to adapt in many ways. Do you mind taking us through a little bit further in terms of what that adaptability, how that adaptability that you learned in your military residency program, how that adaptability played out in other areas of your life, whether it's in your first duty station as the medical director, or either at the Javits Center?
I think it's going into new experiences with the expectation that you will be placed into roles where you are inexperienced or less experienced, right? And must adapt and problem solve and make sure people stay alive. In the military, we cannot quit. I mean, you can, but you'll go to jail, So, but we can't quit. So it doesn't matter if you end up in a job that you don't enjoy. It doesn't matter if you don't get along with your coworkers. It doesn't matter if you struggle in other ways. You're expected to show up in uniform at the right place at the right time, and to do your job and do it well, and to do what's important for the military while you're also balancing that with what's important to you. And so I think that emphasis on adaptability, on controlling what you can control, and in psychiatry, therapeutically, we control such an important aspect of human thinking and how we respond to the world around us, right? By controlling what we can control in these environments that we are placed in, I think that adaptability plays a significant role, right? So I've been honored. I've been very lucky to be placed in a position of leadership on an inpatient psych ward shortly after residency. That also means challenges of managing those who outrank me, right? Of being placed with administrative roles that I have never done before and did not even know would exist, right? And having to learn, adapt, and know when to say, hey, I don't know, somebody help me. And asking for help is certainly not a sign of weakness.
Awesome. And lastly, any other stories that stand out, or anything else that you'd like to share with our listeners today?
I think, I've journaled kind of through this process, or at least I've taken notes on a notebook they keep with me, and I kind of flesh it out when I have a spare moment. And there's one thing that has really stood out. I don't even know how relevant it is to this podcast, but I'm going to say it because it's been one of the most important things that's happened to me here. And I hope that many have experienced this through this whole kind of COVID pandemic. I have been humbled and shocked and just touched by the people that have come out of the woodwork in my life. Folks that I have not spoken to for years, family members who I might, talk to on holidays, right? People that I don't know, but are friends of friends, reaching out on a regular basis, just saying, hey, how you doing? Hope all is well. I got to say, walking down the street one day at 7 p.m. when New York everybody would open the windows and you'd hear the pots and pans banging and people yelling. I had never thought something like that would affect me. And it brought tears to my eyes, not to be dramatic, but I mean, the amount of love that this pain has brought out has been really an amazing thing to see. And I think any disaster or traumatic event can bring out the worst in people, but my God, it can also bring out the best. And I have been really humbled and touched by what I have seen from people in my life, but humanity in general. I think that a lot of good has actually come out of this as well.
And with that, I just want to say on behalf of both Sean and I, how thankful we are for you, Dr. Kaplan, for taking the time out of your day to speak with us, but also especially for the work and the sacrifices you made by deploying to the Javits Center to New York City to commit to taking care of the citizens there who need it. And so I just want to extend our gratitude for you for that.
Well, thank you for the support and the opportunity.
Absolutely. And with that, we'll end there. And for anyone else listening who is interested in learning more about just military psychiatry in general, can check out the American Journal of Psychiatry Residence Journal June 2020 issue. It goes more into various, I think we have 13 or 14 articles or so. There are several articles going into military psychiatry, and feel free to check us out there.
Thanks, everyone.